all for this webinar. My name is Astrianda Suryono, and without further ado, I would like to welcome Dr. James Whiffen, who will be talking about ocular tuberculosis in Western Australia. Please, Dr. Whiffen.
Hello, everyone. Thank you for the invitation. I'll just share my PowerPoint here, and I hope everyone can see that and that everyone can hear me all right. So my name's James. I'm one of the first-year registrars working in Perth in Western Australia, currently based at the Royal Perth Hospital. And I'm just going to be talking about a brief case of ocular tuberculosis, and with a focus on some of the difficulties in diagnosis and decision-making with regard to initiation of anti-tubercular treatment in what is a low prevalence setting for tuberculosis in Perth, or in Australia, really. So this presentation was a 38-year-old Indian male who had immigrated to Australia, who presented with decreased visual acuity in his right eye, as well as a sore, painful red eye on that side as well. On further history of this gentleman, he's an otherwise healthy young male with no other risk factors for other uveitis, and importantly, no direct TB exposure. On examination, he had quite significant bilateral ocular inflammation, including anterior chamber reaction as well as posterior chamber reaction, and in particular displayed perivascular sheathing, probably more so in the right eye compared to the left, but definitely bilateral, with associated intraretinal hemorrhaging as well. And the image I've got there is a composite fundus photograph from actually later on in his presentation, where you can see some retinal photocoagulation has been done, and I'll speak to that a bit later. But essentially, the general impression at this time was a young, otherwise healthy male with a bilateral panuveitis with an occlusive retinal vasculitis picture. So he underwent fairly significant initial uveitis screening, and this is a fluorescein angiogram of his left eye early on in the presentation. And you can see here that vascular leakage temporal to his macula and some involvement superiorly there as well. And you can see essentially his entire initial screen or uveitis screen came back as negative. And I'll just draw your attention to his chest x-ray there, as well as his initial quantiferon gold, both of which were reported as normal or negative. So his initial management consisted of trying to control his intraocular inflammation, which did pose quite a difficult challenge for him. And this involved topical steroidal therapy as well as systemic steroidal therapy in the form of prednisolone. This was transitioned to methotrexate as a steroid-sparing agent quite early in his presentation, in anticipation of what was likely to be quite a prolonged duration of inflammation or intraocular inflammation for him. He also received subtenon's triamcinolone, which was for some macular edema early on in the process. And as you can see in this fluorescein angiogram of his right eye, underwent significant retinal photocoagulation for areas of ischemic retina subsequent to his occlusive vasculitis. This was more so in his right eye compared to his left. So the issue arose as to what his underlying pathology was. And certainly as a result of his clinical findings and his heritage from a TB endemic area, the diagnosis of ocular tuberculosis was high on the list. However, we didn't have significant evidence to prove that. So he underwent further quantiferon TB gold testing, which was returned as indeterminate. He had a T-spot test, which is another interferon gamma release assay, which did come back as positive. He had a high resolution CT chest, which showed some right-sided adenopathy that was thought to be related to prior granulomatous infection. His induced sputum testing came back as negative, as did the results of his bronchial biopsy and his lavage as well, which showed no granulomatous activity, essentially showed no microbiological activity of tuberculosis, and also no evidence of sarcoidosis in that process as well. So in summary, we've got a gentleman with bilateral, quite significant panuveitis with an occlusive retinal vasculitis, who's undergone a suite of testing, which has included immunological testing that is relatively equivocal and certainly hasn't proven active tuberculosis, microbiological testing, which has come back as negative, and radiological testing, which is, again, relatively equivocal. So herein lies the dilemma, and particularly within low prevalence countries such as Australia, as to whether to subject someone to the 9 months of anti-tubercular treatment based on what is essentially clinical diagnosis and a history. And in conjunction with our respiratory infectious disease colleagues in Perth, the decision was made after long discussions with the patient, to commence on full anti-tubercular treatment. And this went over a period of 9 months. He was also continued on his immunosuppressants, which was methotrexate. And that was done for 2 reasons. First being, as I mentioned earlier, it was quite difficult to control his intraocular inflammation. And secondly, we wanted to cover him for paradoxical increased inflammation after commencing anti-tubercular treatment, which can happen in about 30% of cases. He also received ongoing intravitreal anti-VEGF in the form of Eylea for macular edema, which was fluctuating, which was a result or a secondary to a branch retinal vein occlusion he developed in his right eye. And after all of that management, once it had all ceased, so once his anti-tubercular treatment had ceased and his methotrexate had ceased, he was assessed and found to be in full remission of his intraocular inflammation 6 months after ceasing them. And he had his most recent review in March of this year, and this is where this fluorescein angiogram of his right eye is from. And his vision was 6.5 bilaterally. And you can see, he's got quite extensive retinal photocoagulation, but relatively spared macular area. So the learning points from this case that we wanted to discuss mainly revolved around this decision-making with regard to initiating anti-tubercular treatment, particularly in a place that's low prevalence. And the important points of this being that a lot of the additional testing or investigating we'd like to use that can be useful, particularly in high prevalence situations, tends to not provide a huge amount of information a lot of the time. So up to 30% of extrapulmonary TB can be quantiferon gold negative, and certainly in other extrapulmonary TB groups, that value can be even higher. Similarly, radiological findings can often be negative, and microbiological evidence to prove active tubercular disease can be very limited as well. So in recognition of that difficulty, the Collaborative Ocular Tuberculosis Study, or the COTS group, got together to help to establish a set of criteria or classifications, as well as a calculator system to help clinicians make that sometimes tricky decision to initiate anti-tubercular therapy based on largely clinical findings. And I'll just quickly speak to both of those. So this is the COTS criteria for classification of ocular tuberculosis. And the primary reason for undertaking this for the group was to establish a nomenclature, a standardized nomenclature for defining phenotypes typically seen in ocular tuberculosis, in an effort to reduce some of the variability and ambiguity in descriptive terms that had been used in the literature and elsewhere, which has probably been not helping with the difficulty in diagnosing ocular tuberculosis on clinical findings. And you can see this classification system is also consistent with the Sun or the Sun group classification system, and it sits under an umbrella term of tubercular uveitis and is broken down into an anatomical perspective, which includes a retinal vasculitis, which in the past has been defined as Eales disease, and they've stressed the importance at the bottom there about trying not to use this terminology if possible. They went further and developed a standardized nomenclature for defining choroidal involvement of ocular tuberculosis and separated into four more or less distinct entities, that being tubercular serpiginous-like choroiditis, tubercular multifocal choroiditis, tubercular focal choroiditis, and tuberculoma, again in an attempt to help clinicians feel confident in establishing a diagnosis based on their clinical findings in what can be a very ambiguous and variable presentation of disease. And finally, the group also worked to establish this calculator, which is free to use online and very intuitive to use, based on a few key bits of information regarding your patient. And this was developed through a modified two-step Delphi technique with a group of uveitis experts around the world exposed to 486 different clinical situations concerning ocular tuberculosis, and essentially encouraging them to establish a consensus on each of those situations as to whether or not they would consider starting anti-tubercular therapy. That was based on this 5-point Likert scale, which has been converted into the median score, which you can see at the bottom left-hand side. And subsequent statistical analysis developed the interquartile range to further represent a percentage based on, or a percentage representation of the degree of experts agreeing on the initiation of anti-tubercular treatment, which is seen on the bottom right. So for our sake, I've included our patients' features from today. So a 38-year-old male from India with a clinical phenotype of active retinal vasculitis. I've included it as a negative tuberculin skin test, although this was not undertaken, but a positive interferon gamma release assay, which was our T-spot test, and a negative chest X-ray finding, despite us having some potentially positive findings on our high-resolution CT chest. And you can see even with those largely negative results, it has still given us a median score of 4, which equates to a high probability for most experts to consider initiating anti-tubercular therapy, and an interquartile range of 1, which represents greater than 80% of experts agreeing on the initiation of anti-tubercular therapy. So you can see a very practical and handy tool for clinicians to use, particularly in these situations where there may be a paucity of investigational evidence to help confirm your diagnosis of ocular tuberculosis, and having to rely largely on clinical findings and a history. And in summary, that's what the point I'd like to get across today is that in this case, it was relied on largely the clinical findings and history to make the decision to treat this gentleman, and he's had a very good response as a result to that relatively aggressive upfront decision to diagnose this as ocular TB and potentially avoid even further prolonged immunosuppression in this situation. So thank you very much. I'll leave it at that and continue on with our next speaker unless there's any questions.
Thank you, Dr. Whiffen, for a very comprehensive case presentation. I would like to also invite questions in the chat box if anybody would like to ask for questions, and then we can discuss it after all the presentation is done. So next, I would like to invite Dr. Rina Ladistianora, who will be talking about diagnosing ocular TB with limited diagnostic tools. Please, Dr. Rina.
Yes, thank you so much, Dr. Tria, and thank you for inviting me for this wonderful occasion. So it was a very good case presentation, Dr. James, and I will present several slides about how we see it in Indonesia. It is the other way around. Well, in Australia, we can check HLA or we can check everything, but still it is difficult to diagnose ocular TB. Meanwhile, in Indonesia, our problems are limited diagnostic tools. But you can see in ocular TB, actually our clinical judgment is very important. So the problem is ocular TB is actually prevalent in Indonesia, and it is the other way around with Australia, and we are not sure whether to give ATT or not. So we have study in 2014 and 2015. It's a prospective study. We found that a third of the uveitis is infectious. And number one is due to toxoplasmosis, around 19%. And number two is associated with active pulmonary TB. So the patient already have something in the chest X-ray or from the sputum. So it is not hard for us to decide to give the patient anti-tuberculosis. The problem is 2/3 or 66% of these patients came with visual acuity less than finger counting. Therefore, we find it hard to see the pathognomonic clinical signs. Unlike the picture we see previously from Dr. James, we can see directly to the fundus. The patient came to us with many complications of uveitis, such as glaucoma or cataract. So this is what makes us having difficulty in diagnosing them. So we study also at that time, IGRA was firstly introduced in Indonesia. So we see in all healthy control, so no problem with their health, the IGRA positive rate is 29%. So a third of our population is in latent TB. While in all uveitis cases, 66% of them are uveitis with IGRA positive. Among them, only 8% that have clinically active pulmonary TB, which we have no difficulty in deciding to give ATT. 18% has other established cause uveitis. For instance, we can see it is headlight in the fog, it is toxo, or they have aftus in their mouth, ulcers in their genitals, so we can think about the check. But there are around 40% of patients that we don't know what is the cause of uveitis because it is hard to recognize the clinical manifestation, but their IGRA is positive. These patients, we are in trouble. Whether should we treat this patient with ATT? If we follow the criteria from Gupta in 2015, we have to treat them. But we often have difficulty in consulting to our pulmonologists or our internists whether, are you sure this is TB? Should I give them ATT? So this is, let me tell you how we diagnose based on criteria on Gupta. So first, the patient have to have suggestive clinical signs. And if you can see, the clinical signs for ocular TB is very protein. So from the anterior uveitis, intermediate, posterior, until endophthalmitis, it could be TB. So all clinical manifestation could be TB. If we can find the Mycobacterium tuberculosis in the eye, we call it confirmed TB. But if we cannot find the TB inside of the eye, we call it presumed tuberculosis. So this presumed, we can divide it into first probable. Probable is if we can find the MTB elsewhere in our other organs, or from the chest X-ray, it is think that is active TB or a healed lesion, plus there is a response of the immunological test like TST or Mantoux test or IGRA. If this exists, then it is a probable TB. But if one of them is this, then it is possible TB, either MTB elsewhere with chest X-ray or chest X-ray, or there are Mantoux positive. So most of our patients, the 40% lies in this area. They have clinical manifestation that could be TB, and their Mantoux or IGRA is positive. So if it's possible TB, then we have to exclude other etiologies And then we have to try them with ATT. If they gave good response at 4 to 6 weeks, we can say it is possibly TB. So what are the diagnostic tools? First, we have to find it in the eye or systemically or from the immune response. If we find it in the other organ, so the indication is based on internist or pulmonologist, we don't have any problem. The problem is it is hard to confirm the presence of MTB in ocular tissue. This is a very nice study from the team of Nursing Rao, where he's an expert in pathological anatomy from the eye. So they did a retrospective study for around 75 years back, and they tried to collect all the patients with the slides for pathology that have MTB. So they found only 42 patients within those 75 years. And in those 42 patients, they can find Mycobacterium TB in the layer of RPE cells. And it only needs 1 or 2 Mycobacterium TB. So we can see here in the slide, it is very small, only 1 or 2. It already can cause severe inflammation. That's why we call it paucibacillary. And from those patients that have data for their MAN2, only 60% of them is positive. And that explains also the patient from Dr. James, the quantiferon was negative. And out of 14 patients that have chest X-ray, only 43% of them is abnormal. So you can imagine it is actually hard to detect the MTB from the eye. And we also did a systematic review, and we found from all the studies, only 55% could find MTB from the PCR, from the intraocular fluid. So PCR also not a very sensitive test for MTB. You can see because it is paucibacillary and it lies on RPE cells. So you can imagine if we took aqua step and do PCR, it must be very hard to get a positive result. So besides the difficulty to access the MTB inside of the eye, the PCR was also, the positivity is very low. So how about the MAN2? MAN2 is actually an immunological test. It is a memory, so it's not necessarily an active TB. How does the MAN2 test and IGRA test works? So if MTB was caught by the macrophage, especially in our lungs, the macrophage will produce interleukin-12, and it will go to the lymph node and will stimulate the T cells to produce interferon gamma. And this interferon gamma will be used to enhance more killing capabilities of the macrophage. So for IGRA test, the difference is we took the blood of the patients in vitro. So in vitro, we stimulate the blood from the patient with the specific MTB antigen, which is ISAT6 and CFP10. And then we incubate overnight, and we can wait until the T cell produce interferon gamma. That's why it is called IGRA, interferon gamma release assay. So in MAN2, the difference is we do it in vivo. So we gave tuberculin or the MTB antigen subcutaneously, and we can see the response of the skin and look for the size of the induration. This is a study in Cape Town, and they find that patients were 6.95 times more likely to have intraocular TB if the TST done alone, if the TST alone is positive, versus the 2 times more likely if the quantiferon alone was positive. So you can see in the COTS, the collaborative ocular tuberculosis study, they try to do both. And you have to remember in HIV cases, they tend to have negative TST results. This slide is this research is important because we always think that IGRA is a fancy thing, so we have to do it. But actually, in a place in a country where there's difficulty in money wise, we can just do MAN2. It's not different between MAN2 and IGRA. It's just less convenient than IGRA. So we cannot tell whether it is coincidence with the uveitis or it is really ocular TB if we use TST and MAN2. So what to do? because the consequences of TB uveitis is really dire, because you have to give the patient anti-tuberculosis, and it is multi-drugs for almost 9 months. And then there are risk of toxicity. We have plenty of hepatotoxicity in these patients. Because the diagnostic tools is difficult, we have to remember there are other criteria, which is suggestive clinical signs, excluding other diagnoses, other etiologies, and good response to ATT. I would like to suggest that us in Indonesia, we have to chase the clinical signs. So I tried to gather all the studies that found common clinical signs that were associated with good response or a paradoxical response. I mean, when you give ATT, they gave inflammation severely, but actually it is the right treatment. So I tried to make a criteria, and the first one was mostly good response to ATT only, while until number 5, they will give a good response, but you need more immunosuppressives and other modalities of treatment, such as vitrectomy or intravitreal VEGF or photocoagulation laser, and also, of course, steroid and other immunosuppressive. So we start with number 1, tuberculoma. This is an example of our patient, female, 13 years old with miliary TB. And you can see there's a large of granuloma beneath the retina. We can see the retina is still intact, but there are large mass behind it. And on the other eye, there are multiple choroiditis that is starting to heal. And this patient was responding very well after anti-tuberculosis. And this study was also found, this kind of findings was also noted in China, where they found that patient with choroidal tuberculosis only that is active with active tuberculosis, and the clinical signs was tuberculoma. There are a lot of patients in young and have active systemic infection, and the treatment with only ATT will give a good outcome. So you have to remember, if you found tuberculoma, you just give ATT. It is more likely to be TB. And I'd like to mention also about the collaborative ocular tuberculosis study. They used two-step Delphi technique, so they gathered 81 international experts and make them say what is agreeable to start anti-TB and what kind of criteria. So they published this paper. You should check it out. Even only the Mantu or IGRA positive, they will start treatment. And even in endemic countries, the chest X-ray showed a healed scar. They already start the treatment. While in SLC and focal and multifocal, they need TST and IGRA and both the chest X-ray. And second one is enterouveitis. In this patient, you have to find the evidence of granuloma. It is associated in both active and latent TB. But I want to remind you, this is our patient too. There's a granuloma in the eyes in shape of nodules. And don't forget to see the sclera, because in Indonesia, we found that the scleritis, the infectious cause, is mainly due to TB. So this is important to see also the sclera. And the study from the Prof. Gupta also found the clinical signs that is predictive for tubercular uveitis is broad-based posterior synechia and also vasculitis and serpiginous-like choroiditis. This is the example of broad-based posterior synechia. We can see that the synechia is very wide. So if we dilate the patient, it's kind of difficult because there's a lot of synechia already. Meanwhile, in the patient that is not TB, this is they have synechia sporadically. So when we dilate the patient, it's formed like a filiform. That's why we call it filiform posterior synechia. And you can see from the COTSCON, if you look at this study, you please take attention only for the green one. The green one is the median 5 and accurate IQR 0. You can see the expert is absolutely agreeing upon giving the anti-tuberculosis. So if we have anterior uveitis, it is recurrent, and the PPD, IGRA, and radiology positive, we should treat the patient. Even there is a somewhat weak consensus, even if the IGRA was not there in non-endemic countries, they also agreed to give the ATT. Okay, the third one I think is similar like the case for in Dr. James' presentation. We have also male, 35 years old. The IGRA is positive, HIV negative, and other workup that is available in our country is negative, and there is no active TB infection elsewhere. The patient is very healthy, so we didn't even think for TB, but we can see there is vasculitis and there is hemorrhage. Too bad we don't have FFA at that time, and we can see there is edema macula because of the occlusion. And this patient, we gave the patient anti-TB, and then corticosteroid also, and also laser photocoagulation, and also anti-VEGF for the edema. And the patient progressed very well. The visual acuity can reach until 6/7.5 and 6/9. And you can see for the retinal vasculitis, the absolute consensus was reached if the patient have active retinal vasculitis, and especially in endemic countries. In non-endemic countries, there are hardly evidence of agreeing. So the expert from the non-endemic countries was not agreeing about giving the ITT because we can understand the prevalence is low there, and also yeah, I got distracted a bit with the yellow line. And we go next to the number 4 and 5. You can see that until the largest number here, we need more immunosuppressed treatment. For intermediate and serpiginous-like choroiditis, there is a paper from Dr. Sumyava Basu, and they found after they initiate anti-tuberculosis in intermediate uveitis and serpiginous-like choroiditis, they need to give more immunosuppressive treatment. So it is not because it is not due to TB, but after inflammation due to the TB, due to the immune response, is higher. Therefore, we have to add anti-TB in this kind of clinical manifestation. I want to show you that in intermediate uveitis, there is no absolute consensus. It's very hard for for intermediate uveitis to agree upon whether we give anti-TB or not. So we have to see case by case based on your situation. But for pan-uveitis, both for endemic and non-endemic countries, if the PPD, IGRA, and radiology positive, they agree to start ATT, especially if there's no other etiology. So maybe this is like a conclusion for the consensus. First, you have to look at the clinical phenotype. And you can see for serpiginous-like choroiditis, choroidal tuberculoma, and active retinal vasculitis, either one positive for choroiditis or both positive for retinal vasculitis for PPD and IGRA, and the chest radiology, anything that we have from radiology, we should start ATT. Most of the experts said so. But if it's multifocal or unifocal choroiditis, intermediate uveitis, PAN, recurrent granulomatous anterior uveitis, either one or both positive, they need more convincing by seeing the radiology. So if there's healed TB infection, okay, you give ITT. But if there's no evidence from the chest X-ray, they tend to just wait and see how does the uveitis progress. So the important parameter is treatment response. So if we give ATT, there are possibilities of improvement of inflammation or persistent inflammation within 4 or 6 weeks, or worsening inflammation. From this, you can see whether the uveitis TB is true or not. But if there's persistence of inflammation, what you have to think algorithmically is it really ocular TB? So you have to evaluate again whether the uveitis is really due to TB. Did we give the correct dosage for this patient, or how is the patient's compliance towards the medicine? And we have to think also about the possibility of MTB resistant to ATT. And next, if we feel that this is really ocular TB, then we have to think whether we need steroid or immunosuppression drugs, such as insertugenous-like choroiditis, intermediate uveitis, or a paradoxical reaction or Jarisch-Herxheimer reaction. So we need to consult each other and discuss, and also to other departments. This is the example of paradoxical reaction. The first picture is 4 days after initiation of ATT. The inflammation is getting severe. And then 1 week after the addition of systemic steroid, it is getting better. And 1 month after, it is getting clearer. So this is actually a paradoxical reaction. So what we do in limited diagnostic tool? First, we have to look at the suggested clinical signs. And these 5, I think you should remember, because there are many reports on this kind of case. And you have to think about whether this patient will give good response to ATT only, or do we need more immunosuppressive and other modalities of treatment. And please chase the clinical signs, because clinical signs will help us a lot, especially in our endemic country, and analyze the treatment response after 4 to 6 weeks. If it is responding, then it is good. It is an ocular TB. But if it is not, think about the step where if it is really ocular TB, is it the correct dosage? Is there any resistance, or do we need more immunosuppressive? Thank you, and I would like to close this presentation by thanking my team in infection immunology division, and I will give the time back to you, Dr. Tria.
Thank you, Dr. Rina Ladistia. Very comprehensive and wonderful lecture. I see that we have Dr. Joe from Lions Eye Institute joining us also in Zoom. Hi, Dr. Joe. So we have some questions. Perhaps we can have a discussion between all the panels, including Dr. Joe. You may also have a discussion together. So Dr. Tia in the chat box have typed a question. So I think a question is, especially in Australia, in the cases of ocular tuberculosis, is there any latest advancements in diagnostic imaging and molecular diagnostic techniques to improve the accuracy of distinguishing ocular TB from other granulomatous uveitis? So I invite maybe Dr. James or Dr. Joe would like to comment on this question.
Hi there. I'm Jo Richards, and I'm not from the Lions, although I'm friends with all the Lions, but I'm from Royal Perth Hospital, which is where I'm working with James. But no, unfortunately, we have no wonderful, amazing tools. We rely on you people in Indonesia and countries like India, where there's lots of TB. You do lead the way, and we follow what you say, and we follow your articles. I trained in South Africa, so that my background was very much a clinical diagnosis, just the way it is in Indonesia. And in Perth, yes, we do have all these expensive tests, but they're not any more helpful than the clinical diagnosis that you make. And in addition, we don't have skin testing. Skin testing is probably more valuable because it tests for so many more antigens, whereas the IGRA testing only tests for 2. So if the patient happens to not have a reaction to those two antigens, they may not generate interferon in response to the test, whereas at least with a skin test, there's a good chance that one of the antigens may be the one that they're reacting to. James, do you have anything to add?
No, I'm learning all this as we go as well. So,
and thanks, Dr. Rina. That was an excellent and really useful talk.
Yes, we have to rely on our clinical findings, really.
So there's no like a standard protocol if you suspected some TB uveitis that you may want to send to the lab, Dr. Joe?
No. What we did with this patient is what we would do with everyone. And because we see so little tuberculosis, it often takes us months to really be convinced that this is TB. And we discuss it with our colleagues at the TB clinic. They are really, really helpful. And if we say we think it's TB, they will treat, even if we have got a negative radiology, negative IGRA, they will treat purely on the clinical findings. So we're really, really lucky with that. But no, we don't have a magic bullet here. And, you know, we've analyzed our patients over the last 8 years, and the majority of them, it took us a really long time, as in months, to be sure of the diagnosis. So yeah, we're looking forward to the magic test, but we don't have it.
Yeah, thank you, Joe. Actually, I'm quite happy that you said that, because sometimes in Indonesia, the ophthalmologists in peripheral area, they are like doesn't have any confidence to diagnose it, because they think the lab test they have is not advanced enough. And you said it that even you have advanced testing, but you still need to rely on the clinical manifestation and wait and see, right? So that is good. So that's why we have many participants here. So I'd like to encourage them to see the clinical manifestation of the patient and refer early if you think that you don't recognize the clinical manifestation. Because if you just give steroids and then the patient have more inflammation and then they have complications either from the uveitis or from the steroids, and after that, if the patient went to the tertiary referral center like our center, we have difficulty because we cannot see anything anymore. So early recognition of the clinical manifestation is really necessary, actually.
Yeah, very good reminder for all our ophthalmologists in Indonesia, Dr. Rina. Thank you. Any more questions from the audience, please? Maybe anybody wants to directly give questions to all the panel here. Okay, one more question from the chat box. I'll read to you. I would like to ask about how does the management of ocular tuberculosis differ in immunocompromised patients, and what are the current challenges and strategies in preventing recurrence and drug resistance in these cases? Thank you. So I guess it's open for all the panel who would like to comment first. Maybe Dr. Joe?
I think that one's probably Dr. Rina's question. We have very, very few patients that are immunocompromised in Perth, because even patients that are HIV positive, they're all on highly active antiretroviral treatment. I can't think of ever seeing a patient that had AIDS or untreated HIV and TB. And the immunocompromised patients that we do see are usually transplant patients or hematology patients. And because there's so little TB here, I just can't remember ever seeing the two combined. Yeah. And we're also really lucky that we have very, very little drug resistance.
Yeah, like you.
So Dr. Rina, it's for you, that question.
Yeah, actually, it's because Indonesia is #2 of TB cases, and also we have the wonderful combo of TB, HIV, TB, MDR. So it's really a wonderful combo for us here. So we have a lot. So that Dr. Hindun is actually working in my polyclinic, and we have a lot of consultation from the internal medicine patient with HIV, and they have tuberculosis, and we have to treat the tuberculosis while we're treating them with antiretroviral, and we hoping that their immune response is getting better. And sometimes we do need steroids in those patients, even though they are immunosuppressed. If the inflammation is too much, then sometimes we give also steroids with the help of our internists to see the balance, because we don't want to lose the eyes also. But sometimes in these cases, the eyes is already severe, so we just watchful waiting with the anti-tuberculosis, Dr. Joe. So it's actually also difficult. It's as difficult as you imagine. But we
And
try,
do you ever have
our
to
best.
do you ever have to treat the tuberculosis for longer?
Yes, sometimes if it's external, then we collaborate with the internal medicine, because sometimes they need 12 months or more. And sometimes we do need to add like a streptomycin or all the second line drugs. So there's one thing that is more interesting, Dr. Yu. I don't know if you have heard. So in 2016 or 18, I think there are reports from the Thailand people, and also in Korea, if I'm not mistaken. There are many young patients that actually have primary immunodeficiency. So they are lacking of, or they are lacking of interferon gamma. So the interferon gamma was attacked by their immune response. So this young patient have a severe TB, even though they are not HIV positive. I suspect that we also have that, but we cannot prove, because several times in our polyclinic, we have severe endophthalmitis due to TB, and they have this massive scleritis, very melting. Sometimes we have to enucleate this patient because it was very painful, and it can goes to, and it can be bilateral. So it's very, very sad to see. And these patients are better if we give full dose of ATT, and also sometimes we have to add the second line like streptomycin. But they are HIV negative, but they have severe TB. Also, they are in other places like POTS TB, like in the spine and everything. So I think we also have that. But we don't have the capability to check the antibody towards the interferon gamma. So they produce interferon gamma, but then they are blocked by the antibodies that because there's a problem with the immune. It's a one type of primary immunodeficiency.
So they would have a positive IGRA test, like a quantiferon gold, or
yeah, but it's actually one of the tests we can check the IGRA if it's so. In Indonesia, the IGRA sometimes qualitative. They only say positive, negative, indeterminate. If we have the quantitative one, we can check at the mitogen also. Their mitogen really low because there's antibody towards the interferon gamma. It could help us also, but we cannot do IGRA sometimes in this patient because it's very expensive in Indonesia. But you are right, IGRA is one of the marker for this kind of patient.
Dr. Rina, is there any place for immunomodulatory agents in this
especially in the serpiginous like choroiditis, tubercular uveitis, they need immunosuppressive very much. Otherwise, the serpiginous shape of active TB, they can go further and further and further if we don't give. Sometimes we have to go methotrexate or imuran, whatever needs to suppress their inflammation.
Is it widely available in Indonesia?
Actually, methotrexate, you can have it because it's cheaper than the other things. So in ophthalmologists in all over Indonesia, you can get methotrexate, but you have to collaborate with the internal medicine because I think if you use BPJS, the universal health coverage, you need to be prescribed by the internal medicine.
Okay. Interesting.
Your methotrexate would be the number one for us too.
Yes, it's quite cheaper and also effective for uveitis patients.
Thank you. One more question. I'd like to ask about the management of occlusive retinal vasculitis that mimic the TB or CMV infection in immunocompromised patient. And if the workup were positive for both infection, what should we do? Should we treat both the CMV and TB together? Who would like to respond to this question? Dr. Rina?
Yeah, I think CMV retinitis usually happen with your CD4 below 50. If you don't have the capabilities of checking CD4 at the beginning, you need to ask for from the history taking, because like I told you, TB vasculitis in my list is number 3. So it's actually, we need to suppress the immune more. And the pathophysiology is not because they're really Mycobacterium TB probably there, but the immune response is very high. While in CMV, usually the vitreous is not too hazy because they are immunosuppressed. And you can see from the clinical manifestation, it is you should find the 3 clinical manifestation: the pizza-like appearance, or the granular type, or the frosted branch anitis. I think if you can differentiate that, and the vitreous is not that hazy in CMV retinitis, you can tell whether it is occlusive tuberculosis retinal vasculitis or it is CMV retinitis. I'm talking about the limited diagnostic test, because if you have diagnostic test, then you just check CD4. If it's lower, then it's most likely CMV retinitis. I don't know. How about you, Dr. Jill?
Yeah, and if there was a lot of vitritis, I would be thinking more along the lines of TB. If there was no vitritis, then I would think maybe CMV, but you would have to have the other retinitis or frosted branch angiitis features to be thinking CMV. They look quite different. I don't have a huge experience of tubercular retinal vasculitis. You probably have more than I do, but certainly in my experience, they look very different. Similarly, I don't have a huge experience of cytomegalovirus, or I do from my training in South Africa long ago, and I did not see any cases that would make me think this could be tubercular retinal vasculitis. Am I right? Is that what you also experienced, that the two look very different?
The two looks very different, actually.
So tubercular retinal vasculitis is exudative. It's more a perivasculitis, so you get these fluffy exudates along the blood vessels with surrounding hemorrhages, whereas cytomegalovirus, you get the retinitis, and that's the clue.
Yes, I agree. Yeah. The retinitis, the cheesy appearance is really prominent in CMV retinitis. Yeah, I agree.
Yeah, which you don't get in tubercular retinal vasculitis. So it's, again, it's clinical diagnosis.
Yes, it is.
Do we have time for maybe one last question from Dr. Golda? What are the potential complications of ocular tuberculosis on long-term visual outcomes, and how do treatment protocol balance efficacy with the risk of adverse effects in preserving visual function? What do you think?
Very heavy question.
Maybe what?
Yes.
What, Dr. Rina?
I think in general we have to look for complications of uveitis itself. Because uveitis can cause hypotony or cataract or CME, most likely CME. And in tubercular uveitis, there are a lot of reports that they found after the whole thing is quieting down. Sometimes there are lapses of anterior uveitis. So there's a study from Dr. Basu also where he divide between anterior and intermediate uveitis and posterior and panuveitis, and he followed this patient, and after they are cured, they are on remission, they will have relapses, and most of them have relapses of anterior uveitis only, and it's only will respond with only topical steroids. So I think that is what we should watch for, and you don't have to repeat the anti-tuberculosis only to treat the inflammation only. And then you have to watch for the complication of our treatment, because ITT, we got a lot of drug-induced liver toxicity, and also in the eyes, you should find the complication for the steroids, especially about the glaucoma or the cataract. I think it is a general rule. What do you think, Dr. Joe and Dr. James? Probably you have something to add.
I think from our example, the other thing to worry about is this chap had quite extensive retinal ischemia as well, and so vascularization and subsequent results of that would be another whole set of things to be concerned about down the track. But you're treating that with retinal photocoagulation as opposed to immunosuppression and ATT.
Okay. Anything to add, Dr. Joe?
No, I don't think so. I think that's been pretty comprehensive.
Okay. I think, yeah, it's rather late in Perth, is it? I think it's 9 p.m. and thank you so much. I think we don't have any other question, but I think the organizers would like to request for a picture for us, for all of the participants. So if you don't mind, maybe we can take a picture. So if you may turn on your video, and Dr. Miki, could you help assist me taking a snapshot of the Zoom?
Yes, Dr. Asrianda. Okay, good evening, everyone. I would like to invite all of you to open up your camera so that we would conduct the photo session shortly. Okay, we will wait a bit more.
Sorry, I'm still in the car.
Okay, Fernanda.
Okay, Dr. Firna.
Okay.
Okay, I think I will begin taking the picture now. Everyone, give us your best smile. 1, 2, 3. Okay, second page. 1, 2, 3. Third page. 1, 2, 3. Fourth page. 1, 2, 3. And last one. 1, 2, 3. Okay, that would be all. Dr. Asrianda, back to you. Thank you.
Thank you, Dr. Miki. So thank you very much, Dr. Joe and Dr. James. I think we have in total around 100 something participants. So I hope this evening can give you a very it's a fruitful experience for everyone. So good night and have a good rest, everyone. See you in the next meeting. Bye-bye. Thank you.
Good night.
Bye. Thank you so
Thanks
much.
very much.
Yes.
See you later.
Okay. Bye.
Bye.